Debbie, hi, thank you.
Hi, Senator.
Okay, we're about ready to start in a minute.
Okay, I'm just going to pull up my screen just to make sure it pops up.
Okay.
So where did it go? There it is.
Oh, yeah, we see it. Okay, terrific. We see it.
Okay.
So I'm going to open. Okay. Okay, it's time for Kupuna Caucus. Aloha, everyone. I'm Sharon Moriwaki, co-convener with, I think I saw Rep Chun, Corey Chun is on as well. So
Yeah,
thank
oh yeah.
Here. Okay, there he is. Okay. So we welcome you to our weekly or monthly Kupuna Caucus meeting. And we are so pleased to have Debbie Morikawa, who is Department of Health Deputy Director for Health Resources. And she has under her the Office of Healthcare Assurance. And, we've been having some issues in the past, and I'm really glad to see that Debbie's working on reforming our community-based living arrangements and trying to make it more streamlined and consolidated into one place instead of all over the place. And looking at some of the kinds of things that she's been working on, I wanted her to early on talk with us in the Kupuna Caucus so that we can understand where she's going and how we can support her in reforming our community-based living arrangements. So I'm going to turn it over to Debbie, and she has a PowerPoint. So Debbie, you can take it away.
Okay. Am I on the presenter mode? I mean, where it's the full screen or?
Yeah, we see you, and then we see your screen share.
Okay. All right. So thanks for this opportunity to share what we've been working on here at OCA. And this is on specifically on the state licensing side. So what you see here is a title, Hevahi Ola, A Place to Thrive. And really that came across because I used ChatGPT to ask for a title for some of the things that I was trying to do. And this honestly is what came up. So I thought, oh, I like the sound of this. And really, this is all about us trying to look at how can we transform our community-based long-term care system into an environment where we really are helping our kupuna to thrive, not necessarily to just kind of waste away in their last days of their lives, but really a place where they can go and enjoy at least what they have left to enjoy and really have the opportunity to live their life to the fullest as possible, despite all of the conditions that comes with frailty and aging. So essentially, the theme is really that we were looking at our existing structures right now. So you're all familiar with the arches, e-arches, and community care foster family homes. There are three different rules for three different types of residential facilities. But what we're seeing is really that essentially a lot of the same types of residents are in each of these homes. The arches were developed back in the 80s and were really designed around people who could still do things for themselves, but really needed 24/7 supervision because maybe they were getting more forgetful, or maybe they got a little more confused, or maybe they were getting a little more frail and just needed someone to make sure that if they fell, someone would know, or if they needed help, somebody would be there to respond. So that's how they started out. And then as people started to need more care in order for allow them to age in place, the e-arches developed so that if they needed a higher level of care, meaning more of an intermediate care facility level, that they didn't have to move out. They could stay within those arches and continue to get the care, but that more services would then be available to provide the supports that they need. Concurrently, there was the DHS community care foster family homes, and those were basically, I'm told, a social-based setting where a family could take in to Kupuna who basically needed intermediate care facility level services, but it was a social environment. So there weren't all those rules in place about how, dictating the type of care, the environmental restrictions, which are very stringent and strict under the ARCH rules. So a lot of those rules just were not in place. It was really a family taking in two older adults who just needed more supports. And then at some point, the CCFFHs ended up coming over to OCA because, we are the agency that regulates community-based long-term care living. And so now all of a sudden we had three different set of rules, but essentially many times we're seeing the same people because even in the arches, what was happening was, and I'm sure you've seen this, a family member wants someone placed into an arch, even though that person clearly needs more care than what an arch was designed for. They would go to their physician and say, you know what, I need this person to be an arch level, of care so that I can get them into this home. And the physician would sign off. And even though our staff might question it, if the physician, was adamant, no, this is an arch level of care, we accept that as the physician's determination of the appropriate level of care. And so they're placed into an arch. So right now, what you see is you have three different types of regulations for pretty much the same person. But depending on what you're licensed as, you have different rules for each of those types of homes. This is very inefficient and really ends up with fragmented services. It doesn't allow for that continuum of care as seamlessly as we would like. And so what we wanted to be able to do is really look at how can we combine all of those rules and create basically one set of rules for all of those programs so that a person can come in and receive all the services through the spectrum. And you know what, I probably should be advancing this. And so that's what we're referring to as the community care residents or CCRs. Concurrently,
Before we start moving, I think your screen should be larger so that we can see
okay,
it.
so maybe it's not expanded into,
I
Expand.
think if you just click on the display settings at the top, there's a caret and you can swap the view.
See at the top.
yes, I had it there before, but you know what, it's,
Display settings. Do you see that?
I'm gonna
So
stop sharing and start again.
at the top, I see that display settings. Does that go
Okay,
full screen or something like that?
okay, hold on. It is not, okay. Sorry, I'm just gonna go back in. Okay, here we go. Let me see, share and try it again. Okay, are you still seeing just the smaller?
Yeah.
Okay. At the top, it says display settings. What does that look like on
There's
your?
a caret that expands it.
Yeah.
Yeah, so how's that?
And then no, click on the swap the view.
I did.
It's still small.
Okay. Let me try it again.
Yeah, that one. Swap. Press that swap.
I did.
There it is. It looks good now.
Okay, all right, thank you. Okay, so basically
Go
what,
back. Can you go back? Because we've missed the circle one.
okay, so essentially this was really about
Mm.
the whole premise is that we wanted to be able to have better continuity of care, being able to serve the whole spectrum. And so essentially what this is why the change is needed. We wanted to combine all of the different programs into one. We also wanted to remove the arbitrary distinctions between all of the different regulations. So just because you were in an arch, you had all these stringent regulations versus if you're in a CCFFH, which is actually a higher level of care, which should have more regulations, more care requirements, actually has the lowest care requirements and the lowest regulation, which didn't make a whole lot of sense. So by hopefully at some point being able to combine all three, we have one set of regulations that really is going to be regulated based on the level of acuity, meaning the level of care needs that are there and whether or not the caregivers or staff are capable of meeting those needs. And the emphasis is really on looking at the quality of life. So basically, the arch level is a much more regulated, I won't say institutional, but it's a more sterile type of a regulatory process where a surveyor will come in and they have a checklist to look at all of the things that they need to meet, whether, again, we talked about, are the doorways wide enough? Are is the food separated the way it's supposed to be? Do you have a certain height for the tables? There are a lot of technical things that you go in and you do all your checklists. And again, the also reviewed care, but in the care is the documentation in place? Do you have, are your records being kept as they should be? And even though the staff did look at the care requirements, it's not because of all of the other requirements that they have to oversee, not as much time could be spent on, is this person getting adequate care? So this model would basically look at this being in the forefront, saying, what is the level of care that's needed? What has been developed in this care or service plan that says, okay, this is what this person needs to receive the minimum care requirements, and hopefully expand beyond that to how can we provide an environment that will enhance their kind of level of well-being or improve their quality of life. And we're not saying quality assurance, we're really looking at quality of life. This is where a person can hopefully thrive and feel like they're engaging with their caregivers, they're in an environment that's supportive and nurturing, and that they hopefully can enjoy their lives more. So that was why we felt the change was needed. So what's not going to change is that oversight. So we would still be surveying the way we normally survey, that there would be application of all of the same standards, although there would be new standards that we would be adding to this. The annual inspections, still you'd have your unannounced visits that basically are triggered by a complaint, and overall assessment of whether care needs are being met. Mandatory requirements for caregivers, same kinds of things, background checks, although right here in the community care foster family homes, it only requires a nurse aide. It doesn't even require a certified nurse aide. And that's been a concern of ours. Last legislative session, thanks to Senator Moriwaki, we were able to introduce a bill that would propose changing the requirement for community care foster homes to require certified nurse aides instead of just nurse aides, because we really feel that with that higher level of care, you needed someone who had stronger qualifications to provide that level of care. It did not go anywhere, and that was partially our fault. We didn't track it as carefully as we should have, and it died. We're hoping at some point that we can revive that, because we really feel that for those residents in homes, which there are over 1,000 of them when I looked at the last count, that those individuals should get that level of care and be provided that care by a person who has been trained in the caregiving procedures that we would expect in an intermediate care facility. Oh, sorry. Okay, so the next kind of touchy. So these are the proposed changes. For the program requirements, one of the things that we wanted to look at is to incentivize providers to take not just the high-end $10,000 to $15,000 a month type of client, which, that's pretty much where things are going right now. You look at these homes, they remodel, and they're charging between $10,000 to $15,000 a month. Well, our average middle class senior is not going to be able to afford this. So how do we incentivize people to provide care for that level or lower? And so we wanted to look at a way that we could incentivize providers to provide care without impacting their bottom line. So looking at a tiered licensing fee structure based on payer mix. So if they are seeing only private pay, their licensing structure would be higher. They would have to pay a higher licensing fee because they're going to get that recouped with their private pay patient. Residents. If they're taking people who are on subsidies or on that lower scale, then their licensing fees would be much lower because they can't anticipate to recoup that with their fees for that they get from their residents. Um, Right now, with the ARCH rules, I believe that it's that they can only open one home at a time, and they have to prove for 1 year that they can operate at that level before they can open a second home. But we know that in terms of staffing and economy of scale, that it's much better to have multiple homes where you can share staff. So you could actually share a nurse per se over 3 homes. If someone calls out sick on one home, you might have another staff that can go over and cover if there's, if that particular home needs more services. You have just a larger uh, pool to pull from if you have staffing shortages. So we want to encourage multiple homes being licensed under one application. Again, what that would entail is, and we're seeing this already, is that you're starting to see more of a business model. When this stuff first started out as the Arches in the 80s, it was a mom and pop type of model, a family that just wanted to take in a few residents and start a business. We're seeing that this is now more of a business model where people are starting to look at generating revenue off of it and looking at trying to build multiple homes in different locations. So it's not that we want to discourage the mom and pop or the smaller business model, but it's not enough to meet the needs or demands of our aging population now. So in order to build out the system to be able to accommodate more people who are needing care, that business model would work. In the event that these individuals in these homes, remember, we're just going to have one licensing criteria or one licensing structure for all of these homes. In the event that individuals need higher levels of care, one of the key differences is that nurse consultation would be required for those higher acuity cases. And this would work right now where it's mandated in the CCFFHs and the EARCHs. If you qualify for the ICF level, then you would have to have a case manager. We would be looking at anybody who looks like they have more complex medical needs. They would need nurse consultation for that. And that could include just somebody that has a lot of medications, because we see now that people have multiple medications, and there are a lot of different factors that go into determining whether those medications are being administered properly, if they're being monitored and are still effective. And that needs to be reported back to the physicians. But if we don't have somebody that understands all of the medications and their interactions and how to determine whether or not they're still appropriate based on the symptomatology, then, what is the caregiver going to be reporting to the physician? So we need nurse consultation on those types of issues. The annual licensing inspections, again, where we had to focus a lot on just kind of more regulatory things. Now we're really going to look at resident care. We want to focus on the individualized care and service plans to make sure that is everything being addressed that this person needs? And once it's in their care or service plan, is the caregiver following that service plan? Is there evidence that this person's needs are being met by looking at whether or not, one, is there documentation, but as well looking at the residents themselves to see whether or not those care needs are being met. So you're talking about skin integrity. You may be talking about mobility. If somebody needs to be up and around, we will also want to include an emphasis on daily social activities. because we know that people do better when there's more social engagement, when there's stimulation in the environment. And one of the challenges that we've seen in our homes is we see this all the time is that when people come in, people are just sitting in their chairs. Sometimes they're sitting in their bedrooms or they're lying in bed, and there's very little social engagement or interaction between staff and the residents other than care activities. And so we want to really put a greater emphasis on what are those restorative care practices that are going to be in place to allow people to hopefully, again, thrive in these environments. And then as far as caregiver requirements, we really feel it's important that every caregiver is a CNA so that at least at some point they've been exposed to all of the types of training that they might encounter needs for in the home. But in addition to that, really putting an emphasis on competency-based training so that not only have they gone through a program that covers the material, but that there's some mechanism to look at, but what are the basic competencies of that individuals. The other thing that the initial models were designed around was caregivers being able to sleep at night, and we're seeing more and more incontinence in the homes. And when arches first came out, residents could not be incontinent. So I could see where there wasn't as much of a need for somebody to be up at night, but now people are incontinent. And if they're sleeping for 8 to 10 hours at night, we want to make sure that someone's getting either changed or turned and repositioned throughout the night if they're not capable of, adequate mobility in their bed. Again, we have people that are a little bit more how would you cognitively impaired and may try to get up at night, and that's where we see a lot of falls occurring. So again, we're feeling that more and more there needs to be a caregiver awake at night. Again, this would be subject to an assessment of what are the needs of the residents, and if it appears based on the both cognitive and physical issues of that resident that a caregiver should be up at night, then we would need to require and look at whether or not a caregiver really is available at night, whether it's by staffing schedules. It may even be inspections at night. That is something that we would have to take a look at. Okay. What we're hoping that this does is, I guess, reduces the fragmentation by merging all of the licensing structures into one so that someone coming in is going to be assessed based on their ability to provide the care, not necessarily whether you meet the ARCH standard or you meet the CCFH standard. It's really looking at the care plan and determining whether or not these individuals' care needs are being met. Supports the aging in place so that, again, not this person can stay throughout the whole spectrum. They don't have to move just because they're in an E-arch and the E-arch already has 2 residents. So they have to move because now they're at an ICF level. This would allow that home to go up to that 3rd or 4th person, possibly, so long as they provide the staffing. So obviously, if you go up to 3 or 4 people in a home, you're going to have to demonstrate that you have sufficient staffing and you have the wherewithal to be able to care for these individuals in the home. But it doesn't require you to discharge or force somebody to move into another setting. It improves caregiver consistency and oversight, so it aligns the staffing with the care needs as opposed to are they just meeting a regulatory requirement? And again, this last one of the things that I really, it just kind of hits home for me, but it's really looking at many times you have a couple who a husband or a wife has been caring for their spouse and they've just become too frail to continue doing it, but they still want to live together. Being able to go into a care home or CC, our home, and be able to live together and have that support, that caregiver support of the staffing that's available, to me is priceless. And so being able to do that without, it kind of being going against the grain of no arches, you have to be at a certain level of care in order to meet that, or you got to take away one of the arch licensed beds so that in the future, if you need it, you got to go back and get it relicensed. So this allows for that. So overall, as I've been saying, it's going to be kind of modernizing to look at what are the acuity levels today? What are the types of people we're seeing in these homes? But still allow the flexibility for those people that are just coming in from the beginning levels where they don't need a whole lot of care yet, but we anticipate that over time, they will move into these higher level of care categories. Driven primarily by looking at what the care needs are as opposed to the specific licensing categories. And then honoring dignity and culture, looking at, again, residents' preferences, trying to be able to look at, okay, what does the resident want? And ideally, so again, I'm going back to just, and this is kind of a pet peeve of mine, but in institutional environments that are regulated by Medicare, you have to have all of your prescribed, okay, the diet, it has to be a certain way. The limitations in activities have to be based on the doctor's notes. There are times when residents, they're choosing to have take certain risks because it improves their quality of life. So somebody who may have aspiration precautions and aren't allowed certain foods, but the family member or the resident, really wants a certain type of food, they should be able to sign off on risk agreements saying that this is a risk that I'm willing to take, and I would like to have this type of food, even though my doctor says it's not advised. Those kinds of things that we still need to discuss, but those are the kinds of things that I would really like to look at. Are we able to honor the residents' perspectives and wishes? Okay, so that's the CCR, or community care residents. The second model that we're looking at doesn't exist right now. So right now, you've heard of assisted living facilities, but we know them as the plazas or the CCRCs. They have assisted living throughout, like as Arcadia, the whole facility is licensed as an assisted living, or you have places like Halanui. Those usually are for people who can afford a lot of, they can afford that type of care. Again, I'm of the strong belief that that type of environment should not be restricted to people that just can afford to can afford to pay, that it should be made available to anyone who wants to live in that type of environment. Realistically, in Hawaii, because of the high land costs, high costs of development, and the current assisted living requirements that we have in place, which makes sense for the facilities that are in existence. It's cost prohibitive to take in people that can't pay at that level. So I wanted to create a new model, which I'm kind of terming, and these terms are just arbitrary at this point. I'm just throwing them out there just to be able to call it something, are enhanced living residences. So these are like quasi-assisted living. We're really looking at people who want to live in more of a apartment-like setting. So these would be individual units. They would have a private bathroom and a kitchenette. So the kitchenette would have like a microwave and an apartment size refrigerators. The care options would be similar to assisted living, where, it could be someone who comes in and just needs somebody to check in on them every day to make sure that they're okay, that they're reminded of, the meal times, or maybe they need the full spectrum of care and somebody comes in and helps them with their baths, or helps take them to the dining room, or assists them with getting dressed in the morning, but that the care options are available for whatever level they need. It also is an environment that promotes more social engagement, so that it's a community living environment where their peers are other older people that they can connect with, and hopefully can be more nurturing for them. In this model, again, sorry, went backwards. So in this model, what we're looking at, how the development would occur, I've been in discussions with HFDC, trying to see whether or not maybe they can identify buildings that are state-owned or that could be purchased by the state and converted into a residential building. These buildings would accommodate up to perhaps 100 residents. Again, we're looking at adults 60 or older, or people with qualifying situations like someone with disabilities. Each unit would have a call system so that in emergencies, they can call someone and just push a button, say, I need help. The core services would include having the ability to provide supervision and wellness monitoring. So that's the daily check-ins for people that have cognitive impairments or memory loss. But there'd be 24/7 staff on site who could provide assistance as needed. There would be some type of congregate dining program, and that could be something where there's a dining room downstairs where meals are served and people can come down. But there could also be a Meals on Wheels option or a in-room dining program where food could be then delivered up to rooms, so that if people needed to uh, just wanted to stay in their own rooms, they didn't want to go downstairs, that they could. Optional personalized services. Again, this is the a la carte or full spectrum of services that could be offered on site in their homes, and then daily activities and programs. And the way these things would be made accessible would be co-locating services on the ground floor. So I think with Senator Moriwaki's conversations about the facility that she currently has, there were discussions of these concepts. So I just threw all of those things in here just for, again, discussion purposes. So if you had a federally qualified health center or an FQHC on the ground floor, that would give access to primary care services, behavioral health, chronic disease management. It would have the ability to bill Medicaid for people that needed access to those services but didn't want to have to go to their own primary care physician, because that would take getting on some type of transportation, and someone might have to take them. So this would make it much easier if they could just be serviced right on site. If you had an on-site adult daycare or day health program that could also service the community, so people could come in for these services, which would generate income for the program. People in the building could participate in the program so that there wouldn't be need for additional staffing to be brought in just for that program. So, there's, again, program generating revenue that could occur with these shared models. Having a licensed home health or home care agency, again, that's able to provide services to the community, but could also be the staffing model for the facility. Having a pharmacy or durable medical equipment outlet on site so that it makes it easier if people needed to have their homes fitted for something additional to what they already have in their rooms. I threw in the thrift and snack shop because I know Arcady, and I'm assuming they still do, used to have this thrift shop, and they would sell all kinds of kind of little things in there that residents could come in and purchase. And it was run by the residents. It was kind of a quaint concept, but again, it engages people, keeps people active. Food service kitchen or community cafe or dining hub. Again, that's the congregate dining that could be on the ground floor to allow people the ability to congregate with other members of that community. As far as affordability, it could be private pay for the people that don't qualify for any state subsidy, but perhaps there could be sliding scale rates. If they're state subsidized, we could look and see whether or not at some point we could maybe get some project-based vouchers for some of the units, or state housing subsidies, or using the state supplemental payments. And then for the services, using the Medicaid HCBS waiver or assisted living rates to help support the services. So again, this would fill in the gap for independent senior housing programs that have independent seniors that don't need any assistance. But once they start to need a little bit of help, now they have to move into either a CCR or an ARCH at this point, but some community-based home or at some point they might have to move into an ICF facility. So this provides an alternative model to that. It also leverages resources to support equitable access to assisted living for Kupuna across all income levels. And in summary, so the next steps for us is we really do want to engage all the key stakeholders. So we're going to be reaching out, and this was our first step to say, anybody who's interested in working with us on developing out these models, please make sure they contact us. We do need to research the laws required to make the changes in statute to create these two new models. And we also need to look at what are the care competencies that are going to be required for those caregivers under the CCR model, because again, we're saying we want to look more at competencies and not just that you have a certification. And depending on the different levels of care, there are going to be different competencies that are required. And how do we make sure that we have the training components out there to be able to provide support to people who need to develop these competencies? And then the last is we definitely need to be working with MedQuest, and we currently are. We meet with them regularly to look at what these models consist of and how can we incorporate getting Medicaid payments for these two different models. Their waiver covers them from this year through December 2029. And so we know that it's probably not feasible to change the reimbursement or categories until they do their new proposal, but probably in 27, 28 is when we're going to be looking at, 28, 29 is where we're going to be looking at, okay, so how do we incorporate this model of care to be included in their new 1115 special terms and conditions, which outlines their waiver program? Okay, sorry for being so wordy. So if you have any questions, please feel free to contact me. This is my contact information.
Is it in chat or where are you putting it?
Let me put it in the chat.
Okay, so while Debbie's typing in her chat address so that you could all get more information from her and give her input on her model, I think she's done a really terrific job on trying to incorporate what has been an issue in the past of, having so many regulations and this or that, to have it all in one consolidated community-based living. So I really applaud Debbie in pulling this together. Are there questions of Debbie? Just raise your hand or.
This is Jack Lewin, if I could say something.
Yeah, please.
Yeah, Debbie, I think this is brilliant. I really think it's brilliant, and I'm a total fan of this. I think even Medicare beneficiaries who aren't eligible for home and community-based services, maybe they have some assets. If you have the FQHC component downstairs, they could even get the health care they need. So they're left out. A lot of those people, they don't have home health. They're not eligible for a lot of services unless they, get impoverished to the level of being eligible for Medicaid. So I think it's a brilliant strategy, and it's just and also it's egalitarian. We're allowing people who don't have the resources to have the kind of quality of life that we want them to have for their Kupuna later years. Wonderful, wonderful. Thank you so much.
Thank you.
Allows for choice. So, we've always been talking in the long-term care work that we've been doing in the past and talk about person-centered care choices and keeping them in their homes as long as possible or in the community as long as possible. So this incorporates all of that and, looking at it like not a checklist, but really looking at the care at the level of care needed. So thank you, Debbie.
Can I say something?
Sure. Go ahead.
Yeah. Well, one of the things that happened after we worked on the assisted living regulations years ago was we're trying to encourage the facilities to consider Medicaid, and there was a pushback. So consequently, what we did was we started looking at how can we create affordable supportive senior housing. So this is what Debbie's talking about, senior housing with support services. So what we realized was that there's a, a large number of senior apartments all over the state, right? Some operated by the state, others by city and county. But these are just apartments. They don't provide much more. So one thought that we had was if there was a way in which we could somehow find ways of co-locating some community space for a nonprofit to be based there and as a staging area to provide some of that kind of service, that might work. So we worked with Catholic Charities earlier on to see whether or not they could do some of that. And there was agreement. And so Catholic Charities did go into some of the low-income senior apartments with social workers as a way of providing that kind of additional support service. Because as people were getting older, they were also becoming frailer and more prone to all sorts of medical issues. So having somebody there that could provide that oversight was the intent, and there was no cost associated with that. I'm not quite certain how Catholic Charities had it covered, but anyway, that's so. If Debbie plans to move forward, she might want to consider that as maybe a way of as an initial maybe pivoting point to move forward, looking at independent low-income senior apartments as a staging area to get some of that stuff started.
Thank you.
Yeah.
Okay, so Donald and then Lou, I see. Donald Sakamoto, you wanted to say something? You're muted, I think. Unmute. Donald? Okay,
Oh, he might have,
they lost him.
he probably hung up accidentally.
Okay, Lou has his hand up. Lou?
Yeah, thank you, Senator, and thank you, Debbie. I just wanted to say, just in terms of the big picture, that thank you. I think this is a great vision, and Debbie, I'm really glad to see that you're over there at the health department working on that. I've been dealing with OCA for probably the better part of 30 years. I was a hearing officer at the health department back when Jack was the director, and and I sometimes presided over care home revocation cases. And in my capacity here at the Disability Rights Center, we have a lot of clients that are in a variety of care homes. And yeah, I always thought that OCA was a little rigid, to put it mildly. And I think that what Debbie is laying out is a vision which would really try to address the needs of the person rather than trying to fit the peg into the rule and things like that. So I think it's great. But Debbie, this probably is going to take a lot of legislative and regulatory changes, I assume, right? Which I guess is why maybe you're looking a couple of years out.
Yeah, so the first step would be basically for the consolidation for the CCR is Justin has helped us kind of come up with a step-by-step plan. So what we're going to be doing with the arches is kind of reducing some of the regulatory requirements. And a lot of these we believe we can just do in rules. It doesn't require statutory changes.
We can do that now.
Yeah, we can do that now. So what we would do with our interpretive guidelines of our rules is we would basically decrease some of those requirements in the arches, and then we would increase the requirements for the CCFFHs, because right now they really need to be more regulated and need more care. And that's one of the areas that we could really use your guys' help on. I'd like to get some input as to your feeling about requiring a CNA for especially the CCFFHs, because right now it's just a nurse aide and they can sleep at night, which I understand that's how the program evolved. But you got to remember that at an ICF level, most of these residents basically are incontinent and are bedbound. So can you imagine if something happened at night and people are sleeping, it's just, I wouldn't want that for my mom. So that's one of the things that we would require legislation that we would want to come forth and try to ask for again this session, but only if we think we have support, because like I know that there's been opposition, especially by the foster care homes, because it does require another layer of certification for them. But we think that's
Right.
a care issue. It's a quality of care issue.
No, I'd
So
be
anyway, so we
No,
would
I think
come
that
from
would be
each
possible.
side and bring them towards the center. And then in that process, as we're designing the training programs to bring people up and develop that model where, more people could be involved in putting together the homes so that it could be more of a business model. The other thing that we're looking at, which does require legislation, when I was talking to Medicaid, apparently and you guys know this better than I do, there's been resistance in increasing the rates for Medicaid reimbursement in the community-based homes. Medicaid supports this, but the legislature has not approved the rate increases for that higher level of care. They've kept the rates really low. So this is where I need some help in really understanding this and really making a case where, okay, if you really look at it, by keeping someone in the community, right now, Medicaid may be paying $2,000 for this person in the community. They're paying $10,000 to $15,000 for this person in a nursing home. Why can't we go up to $5,000 in the community and keep them out of the nursing home? But we need to come up with people that can put that case together and go and say, is there some way where you guys can support increasing that rate, because we're never going to be able to get people to take them in the community without increasing that rate.
No, exactly. I mean, I'd be happy to work. I mean, I worked for a long time on this thing called the Challenging Patients Task Force. We had lots of clients that ended up in a hospital, and then a hospital wanted to discharge them, and then they couldn't find a care home. And I've been saying this for a long, long time, that Medicaid needs to have sort of a differentiated rate, because if you run a care home, let's face it, for that same $2,000, you're going to cherry pick. You want someone that's going to be just going to sit there in front of the TV all day and basically be quiet. Do you want to take that person, or do you want to take the person that has behavioral issues or is overweight and has more needs? So Medicaid clearly should be recognizing the differences that each patient presents.
Right. So Medicaid does. It's just it requires legislative approval for that higher rate. And the legislature right now has not approved reimbursement at the higher, because the state has a matching cost. So if we increase the Medicaid rate, that increases the cost for the state. So that's why, there's been resistance to increase that rate.
No, well, that's a good idea, because I mean, it'll save money, because you're right. I mean, instead of a nursing home, or in the meantime, these people back up in the hospital, they clog them up, and then the hospitals are eating huge costs because they're not getting reimbursed because the person is no longer at an acute level. So, so yes, I think that is a great idea for next session.
So Debbie, just talking about costs and comparisons, who collects that information? I don't know, Jack is on, whether SHPTA gets that kind of info, who or DOH gets that information on how much it costs a person to be in a nursing home versus in a community-based facility outside the home.
MedQuest does have some of that information because they're the ones who are paying for the service.
Okay, so we should actually look at that, because what you bring up is a really good point, is if we raise the rates, it's the return is greater because it costs less. And so we're actually paying less for the service rather than having the person go into a skilled nursing facility, for example.
Right.
Well, that's something we should actually work on, because I know that maybe we could get help from Rebecca Kai from OETS, because they're looking at AI and how to use data to do some of these kinds of analysis. So that might be something I'll put on her plate. I put all kinds of stuff on her plate, but it might be something before the next session to at least give some estimates of what we're looking at, because I know we've been trying to increase rates for the community-based services.
Okay. I don't know, Donald, did you ever get your question answered? I can't remember.
Oh, wait,
your hand is still up.
Then he went off.
Yeah, but he's up now.
Yeah, thank you. Sorry I got cut off, but Donald here, Sakamoto. I'm a senior, 63-year-old blind senior. I went to Ho'oponopono, a state agency for blind, to learn about to be independent as a blind individual. Now I'm in my senior. My concern is having the CNAs and nurses to be aware of persons with disabilities, like, you know, deafness, blindness, how to work with them, know what the barriers that they have to go through when a senior goes blind for the first time or loses their hearing. Also, Title VI of the languages. A lot of people who go into these care homes, if they are Filipino caregivers and they're Filipino, no problem. They can talk in their native language. But other ones like Koreans or other languages may be a barrier, and it's very difficult for the caregiver to interact with these people. If they have some kind of, have a language interpreter or some kind of device that can help them know what's going on so they can communicate better. And then also the statewide independent living council, I belong to that organization now. We had a nurse therapist talk about motion sensors in the home. So if somebody collapse and they're unconscious, they can basically get emergency right away instead of having a button to press for emergency, like caller ID.
Thank you.
That's great, because I think that the reason we want to have these stakeholder meetings is to really bring forth a lot of these concepts that maybe we didn't think about that needs to be in place. And again, we're trying to limit the cost to a program to put all these things in place. So what we might want to end up doing is looking at, okay, well, so what are the key things? And you know how like hotels have certain ADA accessible rooms, and they've built out those rooms specifically for people with special needs. So we could have these units where there are a certain number of units that are built specifically for either hearing or vision impaired, so that people that come in, which, because it's not typical that we would get someone like you, Donald, where, you know, you're still up and around and functioning, where these kinds of devices would be helpful. A lot of times what the people that we tend to serve, so we don't think about this, are people who are already in wheelchairs, are being helped. And so we don't often think about, well, what would somebody who's actually mobile, is functioning every day, what would they need in a unit like this? So that would be helpful to get feedback when we have these meetings.
Okay, thank you.
Okay, so any other questions? We're kind of coming up to the hour. It's been very, very helpful, Debbie. We appreciate all you've done, all the work you've done, and you can see the interest in what you're doing. We've had OCA problems in the past of being inflexible, so this flexibility and really looking at the care of the individual and level of care of the individual. I know it's going to take a lot in terms of retraining, maybe, and that's something that you might want to think about in terms of bringing back to us, is how we might help you in terms of changing the culture, but also the competencies if you're looking at care instead of checklist of, whether the door is wide enough.
Well, from talking to our staff, I think there is the culture of wanting to improve the care for people, and that's their primary focus. So our staff, that's what they'd like to see, that people are more engaged, that they're able to have the quality of care that they really feel they deserve. And I want to really thank Paula and Justin especially, because Justin is the section chief for this program. And he has been very innovative. He's the one who comes up with a lot of the ways that we can work through this and how we can make things happen, as opposed to, say, no, we can't do this, no, we can't do that. So Justin has been great. So I think we have the pieces in place to really move this forward. It is very in labor intensive. It's a huge lift. So we're going to ask for your patience. I anticipate this is a 5 to 10 year project. And so, it's going to be a slow process, but we want to make sure that we get it started, because I don't know that anybody else is going to want to take on this kind of a magnitude of a project.
Great. It's great. Yeah, it's an overhaul, basically.
Yes.
So I see Rick. Rick, you have a comment or question?
Well, both. Debbie, thank you so much for the presentation. I think right place, right time. Kind of wish we were already there. So, but by the time we get it, I'll probably be using it. So we're on the right path. Senator, I was going to ask though, in November, are we going to be vetting potential bill stuff like we usually do? Is that the annual
Yeah,
kind of
November,
time to do that? We haven't talked about that yet.
yeah, November or December. I think November we usually ask for the proposals coming in. So yeah, I think so.
I was
think-
thinking maybe there's something in here, Debbie, even setting up a task force to help you.
Yeah,
And
Deb,
maybe that's
Yeah,
something we
I
want to
would
do.
rather not have it in a bill because then it's subject to sunshine and that's going to be very restrictive. I would just rather it be stakeholders coming together. People can come in and out of it. We don't have to sunshine the meetings, and sunshine meetings become very labor intensive and it's very restrictive.
I know I meant to be a.
I think
Okay,
Debbie's
you.
got is you can talk more freely and you can really start massaging this to get something. And Debbie, if in fact you start getting closer to getting something together in which you need to have policy change that would help you, then bring that forward. But we're looking maybe November calling for I guess the November meeting would be calling for proposals, but we have until December. I think we meet in December, so we have time. Yeah.
Okay.
But the earlier the better if there are bills, because we still need to draft them.
Okay.
So are there any other questions of Debbie? Thank you so much, Debbie. Really appreciate all the work you've done to date and will be doing. And thank you for sharing with us. I think you get the feel for this group on the real excitement of seeing reform and community-based housing. So thank you so much. And we'll keep in touch. And Debbie put her contact numbers on the chat, in the chat. So take a look at that and feel free to contact her. We are getting close to the end of the hour, so we will send something out. Charles is no longer with us, so we are not quite on schedule, but I'll have Alex look at that and we can call for proposals.
Okay. All right. Thank you, Senator.
Thank you. So the next meeting will be on December. Oh, I don't have it here. And when December, the first week in December, and we are going to hear from Marilyn Seeley on long-term care financing.
Is it November 7th, though? The next
November, oh wait, is that? Oh, November 7th, right?
Yeah, Senator,
Yeah.
November
Yeah.
7th is the next one.
Yeah.
Okay.
Senator, could I quickly suggest a future topic? For a
Sure.
second?
Yeah, you could.
Okay. Yes, I see that on the agenda. Yeah, I wanted to have a chance to maybe introduce Steve Danzig, who's a longtime friend and colleague of mine. And I think he has something that would be a good future topic. Steve and he can speak himself, but he has cerebral palsy, and he has talked with me about the impact of aging with cerebral palsy, which is something that I was not fully aware of, and I think it shows. You know, I sometimes come to these meetings, but because it's more focused on aging than disability, it's not always the main meeting that I attend. But I think that the issue he's going to talk about really shows that perfect intersection between aging and this. So if Steve can talk for a second, I think you'd be interested in hearing what he has to say, and then you might consider that for a future meeting.
Mahalo, Lou. I thank you, Senator. And Debbie, what you talked about today is actually a great tie-in. I met Lou about 24 years ago, and back then I was using one cane to get around. Now I require a power wheelchair. So my work with the CPD Association now, we just launched a study, and right now it's very early.
Stephen, I hate to cut you off, but we go until.
Okay.
So we will have you at one of the next meetings.
Perfect.
So that we can come back to you.
Perfect. Thank you so much.
Thank you.
Thank you.
Thank you. Okay. We have come upon the hour, so I'm going to close the meeting and see you in November. And Alex will send out information on legislative proposals and our timeline on that. And so we'll hear about long-term care, and maybe Stephen, we can hear from you in January.
Thank you. Thank you so much.
Okay, very good. Thank you.
Thank
Okay,
you.
thank you, Senator.
Thank you.
Mahalo.
Aloha.
Aloha.